This presentation is on treatment of impetigo. Hello everyone, my name is Shikha Patel Shah and today I am presenting a case on a pharmacological management of impetigo. Our patient is Emily Davis, an 18-year-old female presenting with multiple honey-crusted lesions on her face and arms. The lesions have been progressively increasing over the past few weeks and are associated with mild itching but no pain or systemic symptoms such as fever. Based on her presentation, this consists of non-bilious impetigo, most commonly caused by Staphylococcus aureus or Staphylococcus pyogenes. The first line of pharmacological treatment for this patient is topical mupirocin 2% ointment, which belongs to the class of topical antibiotics. Mupirocin works by inhibiting bacterial isoleucine tRNA synthetase, which blocks protein synthesis and ultimately leads to bacterial cell death. It is particularly effective against gram-positive organisms such as Staphylococcus aureus and Staphylococcus pyogenes. From the pharmacokinetic perspective, mupirocin has minimal systemic absorption when applied topically, which makes it very safe, especially in localized infections like this case. Pharmacodynamically, it achieves high local concentration at the site of infection, allowing for effective bactericidal eradication. Topical treatment is preferred in this patient because the infection is localized and there is no systemic symptoms. The second line of treatment option is oral cephalexin, the first generation cephalosporin antibiotic. Cephalexin works by inhibiting bacterial cell wall synthesis through binding with penicillin binding proteins, leading to bactericidal activity. It is well absorbed orally, reaches peak plasma level within about 1 hour, and is primarily excreted through kidneys. Pharmacodynamically, cephalexin demonstrates time-dependent killing and is effective against MRSA, which is methicillin-sensitive Staphylococcus aureus and Streptococcus pyogenes. This medication is typically reserved for patients with more extensive disease, multiple lesions, and those who do not respond to typical therapy. For this patient, the exact prescription would be 2% mupirocin. The patient would apply a thin layer on the affected area 3 times a day for a duration of 5 days. It is important to gently cleanse the lesion before applying the medication to enhance effectiveness. If the infection were more extensive or not responsive to topical therapy, an alternative would be cephalexin 500 milligrams taken orally 4 times a day for 7 days. Mupirocin is generally very well tolerated and has minimal systemic drug interactions due to its limited absorption. The most common adverse effects are localized and may include mild burning, itching, or irritation at the application site. For cephalexin, common side effects include GI symptoms such as nausea and diarrhea, as well as potential allergic reactions, especially in patients with a history of penicillin allergy. There is also a potential interaction with anticoagulants such as warfarin, which may increase the risk of bleeding, although this is relatively uncommon. Monitoring for patients on mupirocin primarily involves assessing clinical improvement. Patients should begin to show noticeable improvement within 3 to 5 days, including reduction in lesion size and crusting. It is important to monitor for any signs of worsening infection or spread. For patients on oral antibiotics like cephalexin, monitoring includes watching for allergic reactions, gastrointestinal intolerance, and in certain cases, renal function, especially if prolonged therapy is required. In addition to pharmacological treatment, several evidence-based non-pharmacological measures are important. These include gentle cleansing of the affected area with soap and water, removal of crusts prior to applying topical medication, and maintaining good hand hygiene. Patients should also avoid sharing personal items such as towels, clothing, or razor to prevent transmission. These interventions help reduce bacterial load and improve treatment outcomes, as supported by clinical guidelines. Moreover, patient education is critical for successful treatment. The patient should be instructed to apply the medication exactly as prescribed and to complete the full course of treatment. Hand hygiene before and after touching lesions is essential to prevent the spread. Patients should avoid scratching the lesion and keep their fingernails short. They should also be advised that improvement should occur within a few days and to seek medical attention if infection worsens, spreads, or if systemic symptoms such as fever develops. The treatment approach for this case is supported by evidence-based clinical guidelines and peer-reviewed literature, including the Infectious Disease Society of America guidelines, American Family Physician reviewed articles, and systemic reviews on Impetigo management. Early recognition and approach of appropriate topical therapy in Impetigo is not only leading to rapid resolution but also helps preventing transmission of complications, making targeted treatment essential in clinical practice. Thank you for watching.